Welcome, Greek U Nation, to episode number 442 of the Fraternity Foodie Podcast. I'm your host, Mike Ayalon, CEO of Greek University. I'm a speaker and an author. Our fifth book just came out. It's called Perseverance and How to Be a Great Fraternity or Sorority Alumnus. So I want you to go up on Amazon or Barnes & Noble, pick up that book today. We call these episodes the Fraternity Foodie Podcast because there is nothing like great food to bring fraternity and sorority leaders together. Fun fact, I've been working with Middle Tennessee State University Center for Health and Human Services for the last 3 years on a HRSA grant called the RCorp Implementation Grant. And the purpose is to reduce stigma and prevent opioid use disorder and overdose deaths in our rural county in Tennessee. We've made great progress in implementing a diversion center for first-time drug offenders, so that way people get the treatment that they need and get their record expunged after successfully completing 6 months in the program. And guess what? We have a 75% success rate. We're also offering MAT, which is medically assisted treatment, to those who don't have insurance to pay for treatment. And we even have Uber rides set up so that way folks who don't have transportation in our rural county can get to a treatment center and back home for free. So I'm super excited about our progress, but there's still much more work to be done. And speaking of opioids, we are going to talk to our next guest about some of the progress that he's making in the area of preventing drug abuse. Mike Vasquez, his own mother, was a victim of the opioid crisis in 1961 and struggled with addiction for the rest of her life. Mike started a business that helped thousands of opioid-addicted patients successfully detox. Mike also filed the first prevention patent in the opioid crisis. He's been named to the Ernst and Young Entrepreneur of the Year Hall of Fame. He received the National U.S. Chamber of Commerce Blue Chip Enterprise Award. He developed the first electronic medical record system with artificial intelligence to go public on NASDAQ. And he's also been endorsed by a former U.S. drug czar and former DEA head. He has saved large self-insured employers millions of dollars a year in healthcare costs and liabilities and save lives in the process. Welcome to the show, Mike.
Michael, thanks for having me.
Hey, it is an honor to have you on the show. We have all kinds of things in common. And I knew when we first met, I said, you have no idea how entrenched I am in opioid use disorder, reducing stigma, reducing substance abuse. And so, I thought that this was actually the perfect fit for our audience. I couldn't think of something that would be more practical and more relevant to today's college students. And speaking of college, you and I were talking before we got started here. You mentioned to me that you joined Kappa Sigma at the University of Iowa. Tell our audience what was special about Kappa Sig that made you want to join them over other groups.
It was kind of interesting. Keep in mind, this was in 1975, and the drinking age was 18.
Right.
And so the Kappa Sigma house had two unique things that I thought were dichotomies. One was, as a house, academically, it was really viewed as one of the leading houses on campus, but on the other end, it had one of the most successful intramural teams, and that just intrigued me that I could kind of get both sides and then still take advantage of the under 18 drinking. So that'll tell you kind of sometimes what draws you to a fraternity.
Yeah, it's so interesting. Yeah, of course, now drinking age is 21. I would love personally if we could go back to 18 years old for the drinking age. I really believe it would save lives. And I think, you can just look at the data from Europe to show that what I'm saying is true. But, obviously there's a lot of organizations that are here in the United States. It gets into politics and all kinds of other things. I just don't think that we can put it, back in the box now that it's 21. So that's really fascinating to me. And of course, you joined even before Animal House was released. I think Animal House was what, like 1979, something like that?
Yeah, I don't know. That sometimes I think maybe we were the model for that. So.
You might have been the model. It might have been Kappa Sigma in Iowa. And, the other interesting thing about you is you actually transferred. You are actually a proud alumnus today of Drake University. So what made you transfer from the University of Iowa to Drake?
As I came from, as I was at Iowa, my family, or my mother actually did not have a driver's license. She had come from Ireland when she was 17. never saw a need for a driver's license, and my father had passed away. And so at that point, I came home to help really at home with a younger brother and to provide some support, even from commuting for her and having access to just getting back and forth to the store. Keep in mind, there wasn't Uber back then. And so obviously wanting to complete my studies, I went ahead and saw Drake University had a great opportunity for me to do that. I took advantage of it. It was a great experience.
Nice. All right. Well, I'm happy it all worked out. Certainly, you've been very successful. So you can't even second question it. I mean, Drake has been very good to you, and you even earned Alumnus of the Year way back when. So that's always a nice honor when they recognize you for your efforts. And
Yeah.
the other thing was you led the first EMR, which is electronic medical records. You led the first EMR company, and you had integrated artificial intelligence. Eventually, you went public on NASDAQ. That just seems like a dream to many of us listening here. What was that ride like to go public on NASDAQ?
It was an evolution. I think the best way to explain it. It was a tech train. Keep in mind, this was 1992 when we started writing the first lines of code, but the AI predated that. Carnegie Mellon had donated $50 million to Creighton University. And it's a long story, but Creighton University reached out to me to help them commercialize that product. But I saw that an AI tool at the time on its own really wasn't viable. However, if you could encompass it with the documentation tools that would allow it to have value to a hospital, then the AI could be utilized underneath that. So for example, 35% of the time when a doctor came to visit you in your hospital room, the patient chart wasn't there. It was with you because you'd gone down to X-ray, you'd gone down to lab, and it was hard copy. But if it was automated, that trip wouldn't be wasted. And so what we did is we built tools so that that patient's chart could be stable, electronically available, and then decision tools underneath that can help enhance so that a nurse or a physician group or a hospital in Kearney, Nebraska could have the same knowledge as a Harvard-trained nurse or physician and utilize that knowledge to help get better patient outcomes. And that was the mission of really what we built. Then obviously the market accepted it. In 1992, there were only 2 companies in the entire US that had a deliverable. We were the largest, but our hospitals were very small. We only had 85 hospitals, but obviously the opportunity was gigantic. And we had several banking firms as we went to Wall Street who said, this could be the start of an industry. Got a commitment, took the company public, and the rest sold it to 3M Healthcare. 3M really owned AI at that time, and they wanted to have our product as part of their offering. So we sold it to 3M Healthcare shortly after going public.
Wow, what a story. What a ride. I mean, you talk about AI. I mean, everyone thinks that this is something that just came around last year, but obviously this has been around a long time, right?
Yeah, it's really been something that when we got into it, it had already been, there was an entire department. So I decided that when I built the model of what I wanted the AI to do, we didn't have the staff available. And in Des Moines, Iowa, it was very difficult. So what we did was we went to the universities, and unknowing to me, both the University of Iowa and Iowa State University had very in-depth knowledge of AI and departments that had degrees even going on in that. And so at that point, I decided to have a bake-off, scope the solution, the product that we want delivered. And I had both university PhD programs write prototypes for that. Eventually, Iowa State University was selected. We completed the project, did a tech transfer into the company, and then took it public from there.
Amazing. What a story. That is incredible. Well, you're obviously very familiar with various universities, spending time both at Drake and the University of Iowa, and also you're a Kappa Sigma. So you understand this question. I mean, alcohol and drug abuse, this continues to be a major issue on college campuses today. So in your opinion, how can today's college students who are listening right now, how can they take an active role in reducing alcohol and drug abuse?
I think the things that we dealt with we used a cognitive technique. And I think as I think back 2 experiences, one, we ran one of the largest alcohol and opioid detox centers in the country. Treatment programs, we had 300 patients in residence every day. And the one commonality, regardless of your socioeconomic background, regardless of your education background, was that the day you walked in the door, you had lost hope. And so what we spent time was trying to figure out, why had you lost that hope? And the common answer was always, I never could believe it could happen to me. It didn't matter who you were, whether you were an attorney or whether you were a truck driver, you just never could believe it could happen to you, because what I found, or what we found, is the fact that it's a chemistry problem, not a character problem. And so based on that, when you're young and you have, let's say, an injury and you're prescribed an opioid, or you're on campus and obviously alcohol is available, then at that point you have to make sure that it doesn't become something that part of your normal course. It can be socially available. It may be socially something you do the rest of your life. But if you can't manage it past the social portion of it, and it starts to affect decisions, outcome, performance, then at that point you really need to step back and look. And the best way to do that is have somebody who will work together with you, making sure that we don't get this out of control. Let's go out and have a few beers tonight, but let's make sure nobody drives home. Let's pre-plan for those sort of things, because those are things that I've seen already. It can happen and you can't go back and fix it, as you well know.
Yeah, I like that pre-planning. I think that's super important. I talk to the students frequently about just setting a drink limit, even for themselves, and let your brothers know what that drink limit is, So you can basically say, okay, today I'm going to have, 3 beers tonight, and let your brothers know, and then keep track of that. I think that's really important, in terms of accountability. And I love that plan in terms of how we're going to get home. I think that's super important. Let's talk about that in advance. And you know what? If we go out to the bars with, 5 Kappa Sigmas, we need to come back home with 5 Kappa Sigmas. And if we only have 4, where is that 5th one, right? I mean, that is really, really important, especially as we're looking at stories all over the country. It reminds me, I live in Nashville, Tennessee, and just recently a fraternity brother who was basically on spring break in Nashville ended up getting kicked out of a bar, and the brothers didn't walk him home to the hotel. And then they found his body basically drowned in the river, 5 days later. We have to have, I think, just watching out for each other and being our brother's keeper in essence.
Yeah. Yeah. No, I agree. I agree. Because you never know. And at that age, when you were that young, you're invincible. I mean, that's why in the military, they use 18 to 22-year-olds. It's because of that invincibility. And you really feel that. I've lived it and I've seen it. And you just have to realize that you're not, and nobody's listening to us today is going to believe that or take it to heart. Quite frankly, sometimes you have to experience it, but hopefully you don't experience to the full extent of what can happen. And the way to do that is to just regulate and just moderate, and try and make sure you use it for what it was intended for, is to have a better time tonight as opposed to a time that you won't remember.
Yeah, well, that's another good point. I think the philosophy has changed in that a lot of students today go out with the mission of blacking out drunk, as opposed to let's just have a beer and enjoy each other's company. It's a mission of I'm going to black out and not remember anything that happened tonight. So I think there's a difference. You can almost equate it to for us, perhaps, it was a marathon, but today it's a sprint. And so there's differences, I think, in terms of how we approach alcohol when we were in college versus what I'm seeing today. There's definitely differences there. You mentioned also that you had this responsibility of building and operating one of the largest opioid detox programs in the country with you and your wife. What made you go into opioid detox programs?
As we talked about earlier, obviously at a young age, I'd been exposed to opioid addiction through when I was 14. I came home and found my mother actually unconscious with a needle in her arm. So obviously that would shake any 14-year-old, but more probably directly related to why we got involved was our oldest son and his best friend got involved in opioids soon after high school. I had just sold one of my companies and his best friend passed away. And so at that point, we felt we'd been blessed with time, we'd been blessed with resources, and we thought we'd get involved. And the idea was just to get involved on a small scale. However, just one thing led to another because we felt we needed to control the environment. And fast forward 12 years, and we had built a program that had 300 patients in residence. And more importantly, 80% of the people actually that came to our program, and we're in Des Moines, Iowa, it's not exactly beach country, that came from California, Texas, and Florida, because what we had figured out is really the heart of opioid and alcoholism was really a chemistry problem. And by doing that, I'd hired a group of physicians out of California that worked on chemotherapy side effects. And the brain chemistry was very similar. And by doing that, we applied that to patients who were suffering from opioid addiction, alcoholism, and getting involved in that. What was in our original intention to be a small scale philanthropic effort turned into a career and a mission that I'm still working today.
Unbelievable. You also recently authored a very compelling book. It's called The Untold Story of the Opioid Crisis in American Healthcare. And in that book, you make the argument that artificial intelligence is a promising and transformative tool for preventing drug abuse. How so?
Well, the thing that we discovered, and obviously working with patients for 12 years, having a background in healthcare AI, I found myself after I sold that company to a company in Nashville, actually, and then during COVID, woke up and found myself with hundreds of thousands of opioid data points, and obviously a passion for healthcare AI. And so I started looking at how could we apply this. And having been on the treatment side, I knew the frustration, and obviously we were never going to be 100% successful. And then all of a sudden, the epiphany came that what if I could prevent you from ever progressing to opioid addiction, because then my success in treating you will always be 100%, where I could never reach that once you got addicted. And so with that, I took that on as a challenge. And we found that hidden inside of every patient medical record are actually indicators that you're progressing towards addiction potentially. And so we used AI software to predict that potentiality and then not intervene with you because of the fact that we already had learned reaching out to a person who has an opioid tendency isn't going to work, but reaching out to your doctor. Because buried inside of every medical record is not only those medical indicators, which I was using to find the patients, but actually to find the doctors who were writing the prescriptions to you that were letting you to continue. And so by identifying those doctors, reaching out to them, and then using CDC guidelines that are very well published, our AI could predict and actually pretty much prove that you were not following those guidelines. Because if you were, the patient indicators that we were uncovering wouldn't exist. And so if they existed, that was our indicator that you weren't following those guidelines. Then once you were identified, we asked the doctor to intervene on our behalf, and that's a whole different discussion, but that's really where it came from and how it got started.
Yeah, that's so fascinating. I'm sure, ACEs has to be a part of that adverse childhood experiences. If you have multiple ACEs, that I think your score would go up tremendously in terms of opioid use disorder. So I think that's really interesting. The other thing that I was thinking about too is just last week, I was spending time with a doctor who's been in recovery since 2004. So he actually, his character was displayed in Dope Sick, which I'm sure you've probably seen that series on Hulu. And Michael Keaton actually played this doctor. Now, this doctor is a real person, okay?
Wow.
His name is Dr. Stephen Lloyd. He's been in recovery since 2004. He's a friend of mine. And last week, I was listening to Dr. Lloyd address a group of doctors at a local hospital, trying to reduce stigma, trying to explain MAT and the value of treatment. And really what he said to the rest of the doctors was, when you prescribe an opioid to one of your patients, you better be really careful when you make that second prescription, because chances are, in the second prescription, 1 year later, that patient is probably still going to be using opioids if you make that second prescription. So that's where you have to laser focus your attention and ask yourself, what am I doing here? Is this really the right move? So, if a doctor wants to prescribe a painkiller to, let's say, a student, who injures themselves, they break their leg, they break their arm, they're prescribed painkillers, what should this student consider at that moment when they receive that prescription?
I think the reality of the potential of addiction should be one of the concerning factors. So, for example, as you were just saying, 13.5% of people who are prescribed a 7-day prescription for opioids are still using opioids a year later.
Right.
31% of people who are given a 30-day prescription, so they haven't even refilled it yet, are still using opioids a year later. And so what you really want to do is get to a point where, again, this gets to where hopefully a family member's there with you to help you kind of moderate. but to try to transition to over-the-counter solutions or physical therapy, because again, you're right, I have to have a pain diagnosis to justify prescribing an opioid. So I've had surgery, I've had an injury, or it might be chronic, but I'm dealing with that opioid. And to be aware, you can actually become chemically dependent. So not addicted, but the early phases where the chemistry starts to take over as soon as 3 to 4 days. So it doesn't take very long. And how can you tell that? Is if you miss a prescription, your body responds physically. I'm going to make you nauseated until you give me that script. I'm going to make you anxious until you give me that script. If you feel those sort of effects, use that as a red flag to say, okay, I'm on the verge here to where I'm starting to become chemically dependent. Do I really need this to continue, or can I get by with an ibuprofen to get back to what we call normal daily living? And so that's really the consideration that I would use. And now, obviously, how we get patients and doctors to discontinue is a completely different discussion, but that's the heart of what I would look for if my son was taking an opioid, is to really help him manage that.
Yeah. I was actually, Dr. Lloyd was showing us some of the PET scans of people who have substance use disorder, who have opioid use disorder. And you see that really only those pleasure receptors are really lit up in the brain. Other than that, the stop mechanism of your brain is not working at all. Okay.
Right.
And that doesn't come back until a year, 2 years after you've already basically given up on the opioid. So I think looking at those PET scans are really, really very telling. And that really kind of changes your perception of just how powerful these painkillers are. Now, 42 states are going to receive $26 billion over the next 18 years for the opioid crisis. And certainly, here in Tennessee, we're certainly recipients of some of that money. How is all of this $26 billion going to be spent?
Well, it's kind of interesting in the settlement. It's paid out over 18 years. And the initial gatekeeper in almost all the states is the Attorney General's office. Some have parsed it out to committees, legislative or public committees, to parse it. And can be used for two buckets. There's a small administrative fee overhead that can be used 10%. However, the bulk of the funds have to be used either for prevention or for treatment. So treatment, on the treatment side of the formula, is our expanded treatment beds and access to treatment, medication-assisted therapies, so MAT clinics, get the Narcan in the hands of first responders and expanded that. The problem I've seen so far in that implementation, because it's paid out over the next 18 years, is because there's a lack of prevention solutions, true prevention solutions. These organizations have started to redefine prevention as the prevention of death and overdose, meaning the fact that they're just thinking that by expanding treatment beds or getting Narcan in the hands of first responders is a prevention effort, as opposed to, as what we're talking about, actually preventing the progression to where you never need those services. So I usually delineate with the groups I talk to, is the fact that, do I need to become addicted to take the benefit of the program you're putting in place? Obviously, if I'm not addicted, I don't need a treatment program. If I'm not addicted, I don't need to go to a MAT clinic. If I'm not addicted, I don't need Narcan. And so, do I need to become addicted to take advantage of that program? And if I don't, then how can I prevent that? And there aren't really a lot of answers out there. And so that's really the space we're trying to fill, is to be viewed as a true prevention program. What's one example of that? So a patient comes in and they're refilling for the second time their opioid script. CDC guidelines say that I should actually have you sign an opioid contract that educates you fully to the risks of continuing, under what guidelines will I refill the script, and under what guidelines won't I refill the script. And then you sign it as a patient and I sign it as a provider. Interestingly enough, only 50% of patients who are asked to sign that contract will say, you know what? I don't feel that bad. I think the ibuprofen will work because I don't want that contract in my file. I don't want that on my record, in my record. And so the thing that I would ask also, as you go to a provider, as they start to prescribe you prescriptions, is, do you follow CDC guidelines for prescribing? Because then that'll give me a comfort level that you have some oversight into what you're doing. And so that's really the way we've attacked it, is try to stay on the prevention side of the formula.
Mm-hmm. One other thing I wanted to talk to you about too is because, we are doing treatment and we have some people working in our local jails in Tennessee. You mentioned that 70% of people in America jails, which is 12 million people every year, would be assessed as addicted and that there is a lost opportunity here. What opportunities specifically are we missing?
Well, it was an interesting experience for me. We'd had a high profile person come through our program, and her father happened to be the sheriff of the local jail. Now it's 1,100 bed jail,
Mhm.
and they had 100 beds empty that they rented to me for $1 a year. And so I had 100 cells, and we created a program for the county. And then the jury system put a courtroom in the jail. So when the members came in, similar to what you described earlier, they were adjudicated and they had an opportunity to come to our program for a year or go to whatever incarceration that their crime might have caused. And what we found as we assessed these patients, 70% of them met the criteria for addiction. Now, they weren't in jail for drugs. They were in jail because they carjacked somebody, they robbed somebody, they shoplifted at Walmart, but it was to support a drug habit. But the bigger statistic that's scary is the fact that if those people aren't addressed, aren't treated when they're discharged, which might be 90 days after they serve their term, they will come back to jail 5 times in their lifetime. Sounds like a statistic, and everybody, it's easy to use the term recidivism, but that's 5 more victims. And when you're in a community, that's a chance that I might be that victim. And so that's the last opportunity I referred to is if counties don't put in models like that, because the key thing that people are looking for that they don't have once they've been incarcerated and they're addicted is after they get treatment, they need 3 things. They need housing, food, and housing, a job, and transportation.
Mhm.
And so in our jail system, what we built was we bought school buses. We had 300 employers, several who came in and did job fairs right in the jail because it's so hard to get people right now. And they actually hired the people, and what better person to get? They're going to show up because we're going to get them there. They're going to be drug screened weekly. You can't do that as an employer, and you know that they have to work. And so it's a great way to get a behind the scenes, behind the work lines employee or up front and get somebody you can count on. And then we managed all their money. We had a nonprofit who came in and partnered with us, and the employer actually paid their paycheck to the nonprofit. The nonprofit parsed a subsidy out to them. And then when they graduated, the nonprofit gave them all the money they had saved to get a new start. So that's the lost opportunity I see is that if we don't intervene while they're incarcerated, you've got a captive audience at that point. Once they're gone, the chances to get them may not be till the next time they're arrested.
Yeah, you're 100% right with that. And certainly part of the funding here in Tennessee, we're using for just that, a jail-based transition specialist that helps with that transition, that's meeting with them in the jail before they're released to make sure that they have access to housing and food and jobs, because that ultimately is going to help in terms of that recidivism rate. And I think that investment is it's a great investment because if
Yeah.
you can bring down that recidivism rate from, let's say, 80% down to 30%. Think about the savings for the county. I mean, just in terms of saving dollars. So it's very worth it. And I also believe very much so in that diversion center as well for first-time drug offenders. I think it's a no-brainer. Having somebody go cold turkey in a cell doesn't really help anything. It's also cruel, but that's another conversation. But my point is that these people just need help. They just need to get treatment. And ultimately, if we can expunge their criminal records by saying that, hey, you got to do everything we ask at the treatment center for 6 months, and then we'll expunge your records and just get you back to work. I mean, there's nothing better than that. There's nothing better than that. So that is really the model. And if we can do that in a very conservative place in the country, like Tennessee, I think we can do it anywhere. That's my
Yeah.
opinion.
No, I agree. We had brought in Drake University to do the statistics department. And so they researched every graduate we had of the program. 84% of our graduates, 4 years after leaving the program, were still sober, still working, and more importantly, still alive.
Yeah.
So that was, it does bear fruit. You're right.
It does bear fruit, and you're right. We got to keep them alive. I mean, that's the big thing. Why we need to have naloxone everywhere. I can't help somebody who's dead. Okay. We have to keep them alive in order to get them into recovery and to give hope. And so that's, the step one is just making sure that we keep them alive, which is why, just having naloxone everywhere on every street corner is incredibly, incredibly important. I've been monitoring some of these overdose deaths in Tennessee. And according to the latest statistics that came out in Tennessee a couple of weeks ago, it seems like it's actually leveling off in terms of overdose deaths without that rapid rise that you and I have seen in years prior. And we still have much more work to do, granted, but how are we actually going to finally solve this opioid crisis to the point where now overdose deaths are actually coming down?
I was in a meeting yesterday for an hour with the past president or the head of Tennessee Medicaid.
Mm-hmm.
And we talked a lot about that. And obviously he's concerned about Tennessee because obviously that was where he's at.
Right.
And they've done the things that Tennessee's put in place can only do so much because it's on the treatment side, regulation side. So I'm going to regulate how long of a prescription I can write. I'm going to regulate refills. I'm going to put a lot of oversight, state drug databases in place, but that still can only take us to a certain level. And the only way we can break through, what I'll say is, I think Tennessee they've implemented almost everything I've seen in the industry on the prevention side,
Mm-hmm.
but you have to then address on the treatment side and the administration side, you have to address the prevention side. And that's the only way, because keep in mind, this pool of people who are chemically dependent and addicted, they actually feed those treatment programs. So if you reduce that pool of where those people are coming from, the ones that are progressing from using a painkiller for pain and to get back to normal daily living, and not let them progress to saying, I'm abusing that opioid, then all of a sudden you've just cut down the influx of people that are keeping the opioid problem going. And it does two things. One is obviously it reduces the addiction statistics, but it also reduces the drain on the resources you have that are providing care so they can be more effective. And that's really that's kind of both benefits of what we're talking about. But you have to start getting on the true prevention side, because you're really doing everything in Tennessee that you can do on the administrative side that I've seen.
Yeah, I'm with you. There is no one silver bullet. So you really have to hit on all of these different sectors. And on the prevention side, I mean, we're investing in billboards, basically giving people access to resources. And that's actually been really successful. We've been monitoring every summer kind of the stigma levels in our community. And as we're putting up these billboards trying to reduce stigma around substance use disorder and opioid use disorder, we're actually seeing that people's minds are changing. Number one, they're remembering that they saw these billboards on the highways in Tennessee, which is great. Even a year later, they still remember and can describe what that ad looked like on the billboard, which is wonderful. But also, I think their opinions have changed in terms of the effectiveness of MAT, for example. So that is wonderful. So we're really starting to see some good things happen. But yeah, there's still more work to be done. And I think you're right. I think we have to do even more work on the prevention side. So still more work to be done.
Yeah, I don't think I'll see the solution in my lifetime, but we're going to do what we can till then. So
absolutely. You and me both, Mike. Well, listen, this has been a wonderful conversation, and it's definitely lived up to everything that I thought it could be. So I'm super excited. Thank you for sharing all of this really, really important information with us today.
appreciate it. Thanks for having me, Michael.
Of course, it's my pleasure. And so to our listeners, if you enjoyed this conversation with Mike Vasquez, I want you to like it, and I want you to share it with other college students, because I think this opioid crisis in American healthcare is very real. And you can also pick up Mike's book. Of course, it's called The Untold Story of the Opioid Crisis in American Healthcare. Thank you so much for joining us today, and we'll see you on another episode of the Fraternity Foodie Podcast. Thanks for joining us. See you next time.